This is a review of Chapter 7. We're going to be talking about the immune system. The immune system, as we know, is responsible for body defenses. We've got two kinds of responses in our body. One of them is a non-specific response, and that happens to any kind of foreign body trying to enter the cell, for example, phagocytosis and inflammation. So it's non-specific. It doesn't depend on the antigen or the foreign body trying to invade us. But on the other hand, we have specific response, and that is when the non-specific responses don't work, and now we need something that to kind of target, that is more targeted towards these antigens, and will make specific antibodies against these specific foreign substances. Just a quick review of the anatomy and physiology of the immune system. We have lymphoid structures or lymphatic tissue that is scattered throughout the body, the largest, which is the spleen. I'm going to take a look here at this figure here. The largest, as I mentioned, is the spleen. We also have the thymus gland. We have the tonsils and the adenoids. We have scattered lymph nodes throughout the body. We have, for example, intestinal lymph nodes, the ones in the axillary area. So, and all of these, all those lymphatic tissues are connected to each other through lymphatic vessels. We have two kinds of cells in there, lymphocytes, and if you guys remember, we have T lymphocytes and B lymphocytes. The T lymphocytes are responsible for cytotoxic immunity because they actually go and attack cells, while the B lymphocytes are responsible for humoral immunity because they are more, humoral comes from blood, they circulate in the body, and they eventually make antibodies. And we'll take a little bit of a closer look at those two in a minute. We also have the macrophages, which are phagocytic cells, as part of the immune system. So, if you remember, the tissues that we have of the immune system, we have the bone marrow, which was the red bone marrow where all of the immune cells originate, the thymus, where the T lymphocytes mature. And I'm actually going for the elements of the immune system. We have the antigen, which is a protein component found on the surface of a cell. If that cell is found within my body, that is called a self-antigen. It's also called HLA, or human leukocytic antigen, because at the beginning when it was first discovered, it was thought that they're only present on leukocytes, but they were later found to be present on all of our cells, and now they're called major histocompatibility complex, or MHC. And our immune system should be able to recognize these self-antigens and not destroy them. If they do, though, and they see them as a foreign body, that is how autoimmune diseases occur. So we have self-antigens. We also have non-self-antigens, which are all the antigens that come into our body that are actually foreign to us. And the immune system recognizes them as foreign bodies, and these are the antigens that we want to attack. Sometimes these antigens can cause an allergic reaction, or they can cause an infection, depending on the kind of antigen coming into our body. Going back to some of our immune cells, we have macrophages, and these are present throughout all of our body. We have macrophages literally everywhere in the body. Sometimes they have different names, but they're still called macrophages. They're under that huge general umbrella of macrophages. They start the immune response. Macrophages are the ones that will phagocytose the foreign body or the bug coming in. It digests it and finds the part that causes the disease. It'll find the antigen that causes the disease, and take that antigen and represent it to either the B or the T lymphocytes. So that's what we mean when we say displays the antigens of the foreign material. So again, it'll take that foreign material, digest the whole bug, and look for the part of the bug that will cause the disease. That part is called the antigen. It'll take the antigen and represent it to the T cells and the B cells. Some of the ways that it communicates with the rest of our body cells would be chemicals, and these chemicals are called monokines and interleukins. Interleukins means that these are between leukocytes. So interleukins comes from the fact that these are chemicals that help in the communication between leukocytes. For the T lymphocytes, again, these originate in the red bone marrow. They have to differentiate in the thymus, and they mature in the thymus, hence the name T lymphocytes. And we have these four kinds of T lymphocytes. We have cytotoxic. From the name, this is actually, they're also called natural killer cells. They will find the antigen and kill it. They have no other way of dealing with these antigens. T helper cells, these are the cells that help all the rest of the immune system. So their major role is not really to kill the antigen, but they're more of a supportive cells to the rest of the immune system. T memory cells, these are the cells that we have in our body so that when we're reinfected with the same antigen again, our body will recognize it right away and attack it right away. So this gives us more of a faster response to the second time our bodies are exposed to that same antigen. The T suppressor cells, this helps because sometimes the immune system can kind of get a little bit crazy and it needs to literally suppress itself a little bit, and that's what the suppressor T cells do. Now, out of all of these four cells, which one is damaged in AIDS patients? If you guys remember from AP2, it was the T helper cells. So the T helper cells, again, although they don't kill antigens and they support the rest of the immune system, this is the cell that the HIV virus will target in order to destroy the immune system. Excuse me. Now, the other kind, which are called B lymphocytes, again, they're made in the red bone marrow. They mature, though, in the bone marrow as well, and that's hence the name B lymphocytes, although B isn't really related to bone marrow, but it just helps us to remember that. These B lymphocytes are responsible for humoral immunity. The B lymphocytes will then go to the spleen and to the lymph nodes, and it's really not the B lymphocytes that attack the cells, but they have to change into plasma cells, and these plasma cells can do one out of two things. And you can see here, these right here are the plasma cells. The plasma cells either can give out the memory B lymphocytes. So again, if we're re-attacked by these same antigens, the memory cells will recognize them right away. Or the plasma cells can become activated and start making antibodies to attack the antigen. The two kinds of immunity that we have, again, we have cell-mediated immunity, and that is the function of the T lymphocytes. And those, again, are made so that they attack the cells on their own. So that's why they're called cell-mediated immunity. B lymphocytes, on the other hand, are responsible for humoral immunity, and because they make plasma cells, or they don't make them, but the B lymphocytes change into plasma cells, and the plasma cells make antibodies, and the antibodies circulate within the blood, hence the name humoral immunity. We have 5 kinds of antibodies in our blood, and those are, if you guys remember, they were gamed: IgG, IgA, M, E, and D. The most common that we have in the blood is the IgG. If you have an IgG to any kind of bug, that means that you're immune to that bug. So we all took our measles shots, our hepatitis shots. We should have IgG against the measles virus and IgG against the hepatitis virus. That means that we are immune against those viruses. So having an IgG against something doesn't mean that we are infected with that virus, and it actually means that we are immune to that virus. IgM, on the other hand, this is when a virus or a bug attacks us for the first time, the antibodies that are made on the first response are IgMs. That means that I have an active infection with that virus. So let's say I get a let's say I'm actually going to get sick with the measles and not get the measles shot. So my immune system, its first reaction will be to make IgMs to attack the measles virus. So if I take a sample of my blood and measure the IgMs in my body and they're elevated, IgMs against the measles virus, that means that I am actively infected with the measles virus. Months later, I take another sample. I have no IgMs against measles, but now I have IgGs against measles. That now means that I'm immune to measles. So IgM means that I'm actively infected with something. IgG means that I'm immune to that something. Going on to the IgAs, that would be those are present in secretions. So you can find them in the saliva and in the mucous membranes. IgEs, those are responsible for allergy, so IgE, allergy, and they cause release of histamine from mast cells, and it's the histamine that causes the vasodilation and the swelling that you see in, for example, all the hives that you see in allergies. So the histamine causes all of the inflammatory response that you see caused by these allergens. IgD is really not an antibody that attacks on its own. It's found on the surface of of B lymphocytes, and it helps in the activation of these B lymphocytes. Now for the complement system. Complement system is the very virulent and aggressive part of the immune system. So if all of these cells don't work, okay, the immune system will activate the complement system. Complement system is just a bunch of proteins and different kinds of cells. We don't need to know the names, but they go from C1, which is complement 1, to C9 or complement 9. The only two kinds of antibodies that are able to activate the system are IgGs and IgMs. And they cause severe inflammation and severe tissue damage. But again, that is the last resort for the immune system to be able to attack something. So it will go through all of these cells. If that doesn't work, the IgG or IgM will activate complement system. But again, it's a very aggressive system that leads to a lot of tissue destruction. Now, what are the chemical mediators that all of these cells communicate together with? Well, we talked about the interleukins. There's also histamine. And for the diagnostic tests, okay, I'm going to try to move this so that you guys can see that. Hold on. I'm going to pause it. Okay, I apologize. I couldn't figure out how to get rid of that, but you guys have the slides on your Google Drive. So the diagnostic tests that we do to detect these antibodies, these two, the titers or ELISAs, you take a blood sample and they give you antibodies, presence or absence of certain antibodies, and they also give you levels of these antibodies. Indirect Coombs test, that's to detect if we have the compatibility of the Rh group. So we already know the ABO system when we can get the blood group. So how do we find out about the Rh? Is the person Rh positive or Rh negative? We do the indirect Coombs test. And then there's the MHC typing, or to find out if the major histocompatibility complex on the different cells, if they're compatible or not. And we have to do this if somebody is getting some kind of tissue donation, so livers, skin grafts, anybody that, so before any kind of surgery, the first thing you have to do, you have to find out, are they compatible blood-wise, their blood groups, and then their Rh. And then you go, if those two come back, those two check out, then the third thing would be to do the MHC typing to find out if their MHC are compatible together or not. Now again, going back to some things that we've already talked about, the innate and natural immunity. Innate immunity, this is something that's very nonspecific. So just our intact skin, our tears, the gastric acidity, All of these are innate kinds of immunity that we have and we use regardless of the kind of antigen coming in. Natural immunity, though, is the one that becomes, it's kind of species specific. And this kind of immunity is present even if we don't get the immunizations against them, against these antigens. There's also a primary response and a secondary response to antigens. I'm actually going to take you to this graph. Primary response means that this is the response that happens for the first time we are invaded by that antigen. So let's pretend the antigen is called antigen A. And you can see the body here takes about 2 weeks to respond to that antigen. And then we can see here the elevation of the antibodies, which are usually the IgMs that come out first. So this is our primary response to that antigen. Then the body will make memory cells so that if we are exposed to that same antigen one more time, it'll only take about a day or two to respond to that. You can see that the response is much faster, the levels of antibodies are higher, and in this case it would be the IgGs that make the secondary response. So primary response are IgMs, secondary response are IgGs, and they are very fast because now our body has memory cells that knows this antigen already, and they're able to respond to it much faster. The 4 kinds of immunity that we have, 2 of them are active and 2 are passive. The active natural immunity means that, first of all, to find out if the kind of immunity is active or passive, you want to think about, did my body have to actively make antibodies against that germ? If my immune system had to actively make the antibodies, then this is active immunity. If the antibodies were passively given to me, okay, my immune system didn't have to do anything. I got those antibodies either from through the placenta from my mom, or I got them because of a shot. Then again, my immune system was passively there and did nothing, and I just got the antibodies. This is called passive immunity. So active immunity, there are 2 kinds, natural or artificial. So again, active immunity means that my body or immune system became activated and it actively made the antibodies for protection. If I got that antigen through say getting sick, so naturally exposed to that antigen, that would be active natural immunity. So again, natural exposure to antigen through getting sick, and my body made the antibodies. Active artificial immunity, this happens with shots. So I did not get the antigen from nature, from the environment. It was artificially introduced into my body. So this is our active artificial immunity. So again, immunizations and boosters, these are examples of this type. Passive immunity, again, this is where my body did not, or my immune system was passive and did nothing, and I was given the antibodies pre-made. If those pre-made antibodies came from nature, so they were made, say, in my mom's body, so they either crossed the placenta or or I got them through breast milk, okay, and those are IgGs, that would be passive natural immunity, and that's why it's extremely important, especially for the first few days of breastfeeding, to get that experience, because these IgGs will remain for life. While passive artificial immunity, this is where I got the antibodies where they were artificially injected into my body. So I got the anti-tetanus toxoid, for instance, and this usually gives us short-term protection. You can see here the types of acquired immunity that we have, and the kinds that give us memory or memory cells have to be the active kinds only, because again, this is where my immune system is actively engaged in the process and it will make memory cells, while in the passive kinds my body is not engaged in the process at all, and so I have no memory cells. So these will not be these 2 will bring me memory cells. These will not. Now, another aspect of the immune system, which is tissue and organ transplant. We already talked about this test that we have to do before, but these tests, sometimes the MHC compatibility is not 100%. No, it's never 100%. So sometimes tissue rejection can occur. If it occurs within minutes or hours or even during surgery, that is called a hyperacute rejection. If it occurs over weeks, that's called acute rejection, while if it occurs months or years later after surgery, that's called a chronic or late kind of rejection. So what do we do before surgery? We try to immunosuppress these patients to prevent the rejection. The drugs that we can give are either cortisone, so prednisone, cyclosporin, or azathioprine. These are examples of immunosuppressant drugs. But on the other hand, you've immunosuppressed these patients, so they have a high risk of infections, especially opportunistic organisms. Now we're going to talk about the hypersensitivity reactions that the immune system can do. We have 4 kinds of them. The type 1 hypersensitivity, which is our simple allergic reaction that happens. For example, hay fever, also known as allergic rhinitis, food allergies, asthma, eczema, or atopic dermatitis that we talked about when we were talking about the skin chapter. All of these are examples of the type 1 hypersensitivity reactions. And it happens because it's very simple. There's an antigen that comes into our body. Our immune system sees it as a foreign body, and it develops an allergy towards it. And because it's an allergy, this occurs using the IgEs. IgEs lead to that the mast cells will burst and release histamine, and histamine causes all of the signs and symptoms of the allergies. And the complication, a very common complication, which is life-threatening, is an anaphylactic shock. This is where the allergy kind of happens all over the body. So you have histamine circulating all over your body. There is blood vessels dilate a lot, leading to a very severe life-threatening drop in blood pressure. There's edema or swelling in the lungs and in the trachea, where the person is unable to breathe, leading to dyspnea and even respiratory failure. So you can see here the main causes of anaphylactic shock are the cardiovascular vasodilation and the constriction in the lungs. So what we want to do, we want to give maybe antihistamines. In life-threatening conditions, we have to give them an EpiPen, which is the norepinephrine, in order to reverse these. So norepinephrine, which is a sympathetic drug or sympathomimetic drug, leads to vasoconstriction of the blood vessels. Okay, that'll elevate the blood pressure, and it also dilates the trachea and the bronchi, leading to now that that person can breathe normally. So what are the signs and symptoms that you see on the patient? You're not going to see their blood vessels or their lungs, but the signs that you want to look for, well, the person will become pale. They'll start getting dizzy. They'll get confused, loss of consciousness. They will get dyspneic. They can even get cyanotic if the respiratory failure happens. So these are the swelling around the eyes, lips, and the mouth, and hives. So these are all signs that you want to look for if a person is allergic to something. And if you see these signs, you want to right away try to administer an EpiPen. You want to call 911 if you're not in a hospital setting, but if you are, you're going to give them the epinephrine, cortisone, antihistamines, oxygen, and stabilize their blood pressure. EpiPen is the epinephrine, sorry, not the norepinephrine. Type 2 or cytotoxic hypersensitivity reactions. This is, for example, a response to an incompatible blood transfusion. So what happens is that your body has pre-made antibodies, and then you get the wrong blood in. The antigen and the antibody react together, and the antibody will destroy that antigen. And this is caused by the circulating IgGs. So here's type 2 hypersensitivity. You see the antigens coming in. They are destroyed by the antibodies, leading here to the destruction of the red blood cell that you got. So the red blood cell that is damaged is the one that was transfused into your body, not your own. Type 3 is also called the immune complex hypersensitivity. In this case, you also have an antigen and an antibody that make a complex called the antigen-antibody complex. The antibody in this case doesn't destroy the antigen, but what happens is that this antigen-antibody complex deposits on different tissues, usually in blood vessels, and this leads to the activation of the complement system that leads to severe inflammation and tissue destruction. So, so the difference between type 2 and type 3 is that in type 2, the antibody destroys the antigen. In type 3, they make a complex together. That complex activates the complement system, and the complement system causes all the tissue damage. Examples that we have for this are, for example, systemic lupus erythematosus or lupus can lead to severe tissue damage in the kidney, leading to glomerulonephritis. These are both examples. There are other examples as well. For example, rheumatoid arthritis was another example. The last type, or type 4, that's also called cell-mediated or delayed hypersensitivity. This is caused by the T lymphocytes, and the T lymphocytes will release lymphokines that lead to severe inflammatory response and destruction of the antigen. So, for example, tuberculin test and contact dermatitis. We talked about contact dermatitis a little bit when we talked about the skin. For the tuberculin test, that is the test that it's a skin test. You get the shot underneath the skin. There's a circle that's made around it, and then you come 48 hours later to see if your body responded or reacted to that. That test is using the cell-mediated or delayed hypersensitivity of our body to detect if we have the TB antigen or not. And this is a diagram that depicts the process of the cell-mediated immunity. Autoimmune diseases, these are, again, our immune system is unable to identify our self-antigens, and it starts to destroy them. So this is called also loss of self-tolerance. It could be targeting one organ, or it could be systemic. Examples we have are Hashimoto's thyroiditis, lupus, rheumatic fever, myasthenia gravis, which is the self-destruction of our own muscles, scleroderma, that's in the skin, and pernicious anemia, where we're self-destroying our own red blood cells. You see the autoimmune response is that both the antigen and the antibodies are present already in our body. Antibodies are unable to identify our self-antigens, and they start destroying them. So, for example, in the case of SLE or lupus, again, this is an autoimmune disease. It usually affects younger women, especially in the African American, Asian, Hispanic, and Native American communities. You see here that this right here is called the butterfly rash, and this is very characteristic. It happens on the nose and on the cheeks. This is very characteristic of lupus. We have a large number of autoantibodies. So we have autoantibodies against our own DNA, platelets, and red blood cells. They can deposit, these immune complexes will deposit into the tissue, activate the complement system, leading to tissue damage. This tissue damage can happen again either in one area, for example, like in the skin, and we have that butterfly rash, or it can happen in different parts of the body. So, for instance, it can happen in the joints, leading to arthritis. It could also happen in the kidneys, leading to glomerulonephritis. It can happen even in the brain and the central nervous system, leading to encephalitis. So, it really so if you're talking about signs and symptoms, it all depends on what part of the body is it attacking. We have general symptoms, for example, fever, malaise. These are fatigue. Arthralgias are usually common symptoms. These are kind of more of the general symptoms, but then the more specific symptoms depend on the system that it's attacking. So if it's attacking the brain, that person can start getting depressed or confused, or hallucinations can happen. Even seizures can happen. If it's attacking the kidney, then that person can start developing high blood pressure or blood in urine. So again, the clinical picture of lupus is very wide depending on what part of the body is being attacked. For diagnostic tests, you want to do autoantibodies serum. There are something called LE cells, or lupus erythematosus cells. And other blood work, for example, CBC and ESR. Again, if it's affecting the kidney, you want to do kidney function tests, or a urine analysis. The treatment is usually dealt by a rheumatologist. Cortisone is used very widely for these patients, and also nonsteroidals. But then again, the treatment is kind of have to focus on what part of the body is being attacked. Although prednisone is more of a widely used drug, and works for any kind, either for the encephalitis or glomerulonephritis. Um, but sometimes they need even more severe drugs than, or more stronger drugs than just the cortisone. The case of immunodeficiency is where the patient's immune system is not working, and that's very dangerous because it leads to increased risk of infections and cancers. It could be primary or secondary. Primary pretty much means that we don't know why it happened. It's just that the immune system failed and we're not sure why. Secondary or acquired immunodeficiency, this is the loss of your immune system because of a cause. So it's secondary to another cause. We know what that cause is. That cause could be a splenectomy. So if somebody has severe splenic rupture or severe spleen damage, the only way to save that person's life sometimes would be to have to remove the spleen, so to do a splenectomy. So yeah, we've saved their life, but now they're immunocompromised for life, and they are now considered immunodeficient patients or immunocompromised patients. If in chronic liver diseases, chronic renal diseases, if patients are taking radiotherapy or chemotherapy, all of these are immunocompromised patients. And again, they are very prone to get severe infections and cancers, and they can even get opportunistic infections caused by their own normal flora. It's usually difficult to treat because the immune system isn't responding. You'd have to give them kind of prophylactic, more of a wide, broad spectrum antibiotics before even routine procedures. For example, if they're getting even a dental care done, if there's a splenectomy patient coming in getting some kind of dental procedure done, even if it's very minor, they still have to take these antibiotics prior to the procedure to prevent infections. The acquired immunodeficiency syndrome, known as AIDS, this is caused by the HIV virus. Patients can be HIV positive for a very, very long time without showing signs and symptoms of the disease. It's not until the HIV virus starts attacking the T helper cells, now this person has changed or switched from HIV positive to an active AIDS patient. That latent period depends on a lot of factors, and sometimes we can try to prolong that latent period using antiviral drugs. There are a lot of clinical symptoms and multiple complications that happen through AIDS, and we will be talking through these complications and symptoms as we go from one system to another. The aim in AIDS or in HIV, I should say, is to diagnose them as early as possible and to make sure that we give them the antiviral treatment that they need to, so that we can prolong this latent period right here that we talked about for as long as a duration as possible. These are some interesting facts about the history of AIDS. Um, the one that I just want to, these numbers change obviously from one year to another, so the numbers that you have in your book are a little bit old, from 2006 and 2007. But being a pandemic disease means that there's a lot of research opportunities and a lot of research being done on this through the United Nations or the CDC, which is the Center of Disease Control here in the US. So these are things that you might want to start looking into if this is something that you find interesting. And this concludes this chapter.